Okay, check it, check the underneath, check it. Are you in the medical?
Yes.
Yeah. So are there any precautions in clinical practice?
Yes.
Can you do a C2 in every patient? Can you put C2 screw in every patient?
No.
Obviously, the way I ask, the answer must be no. All right? No. So the next question is, why? Why? In what patients? What are your precautions before you put in the C2?
Just artery inside.
Well, yes, the vertebral artery. So there may be a high riding vertebral artery.
And especially here, the vertebral artery. Yeah.
So,
up here.
so how do you know that the patient has a high riding vertebral artery that doesn't allow you to put in the screw? High riding. How do you know? So we always do a CT angiogram before any operation, because if you hit the high riding vertebral artery, you're going to get into trouble. Okay? Yeah. So you have to assess all these patients with the CT angiogram to look at the vertebral artery, and then you can see the section and see where your screw is going through. Because is there any danger of hitting the vertebral artery? Any danger?
Yeah.
What is the danger? Hemorrhage, yes, but hemorrhage you can control, all right?
Yes.
Yeah. What is more serious?
More serious for the posterior.
Yeah, for the brain. Because if you have an incomplete circle of Willis, the patient will have a cerebral pica, thrombosis, infarction, sorry. Right. So you ischemia. So you need to assess that. So you cannot put it in all patients. If you don't have an angiogram, at least do a CT scan. In a CT scan, you will see that the pedicle is very narrow because of the high riding.
And
this is just a warning. Okay?
It's for here is the artery like this from here, and after that come here. So I see that for the pointer, I see that is called like this. Sometimes put in artery.
Well, so during surgery, you can expose the joint because you can see the joint during surgery. So during surgery, you follow C2, and then you can feel this, all right, and you can feel all the way the lateral mass. So it's important to feel the lateral mass, medial and lateral border of the lateral mass, and you can put the screw directly into the lateral mass. Yeah. If you find that the arch is big, then you can put it through the arch. But sometimes the arch is abnormally big because there is an abnormality of the bone formation, the ponticus. Yeah. Okay. So you can't do that. So the safest way is to put it in the lateral mass, and you dissect along the side here. Go down, safer. So you go down and you feel the lateral mass, dissect on the lateral mass, and put a screw right in the middle of the lateral mass.
This is about if you can cut the posterior arch.
Well, you don't normally need to cut the posterior arch unless you need to do decompression. If you don't need to do the decompression, once you reduce the C1, C2, all right, you don't need to take the posterior arch off. Sometimes in the situation where you have a hypoplastic posterior arch, then you need to remove it for decompression. The posterior arch will not interfere with your lateral mass fixation.
Sometimes odontoid fracture like this, and for the separation like this, there will be compression from under, so you can like posterior arch. And after that.
Well, once you reduce it, there will be no more compression.
No more compression.
No more compression.
Once you reduce it, there's no more compression. So you don't necessarily need to. You don't sort of always need to remove that. Okay, it's only in patients with a hypoplastic ring. It's easy to feel, and then you can feel the lateral mass. Don't go on top. Don't go on top. Okay, you can go on top, but you must be very careful because if you go on top, you can put an instrument here on top, and you can dissect your artery and you free the artery away if you want to put a posterior arch screw. My advice is try not to start with a posterior arch screw. Use a burr off part of the posterior arch and do directly into the lateral mass. That's a lot safer, right?
Yes, I had a burr here. After the burr here.
Right.
And directly.
Put directly in the lateral mass.
Like this artery.
So you use a lateral C-arm and then you go towards the anterior arch of the atlas. Go to about the middle of the anterior arch of the atlas. Okay? This direction. So you go inside about 10 to 15 degrees medially, and on the lateral view you point the tip of the screw towards that anterior arch, okay, around the middle. For C2, you point it towards the lateral mass side. Okay. Yeah, you can put it because in the saw bone it's easy. You can see everything. Yeah.
You
so
can see
go ahead.
But on the surgery, it's difficult to see there. So
I usually like to use a burr, not the oar, because the oar if you slip, then oops, you can again be very famous. Okay. All right. So use a burr.
Here's spinal. Then like this.
High speed burns.
High speed burn.
That's it.
High speed burn here is okay. But after that you see.
Yeah. So what don't you do now? Do now. Yeah. Do now. A bit lateral, slightly lateral. Slightly more lateral.
Like here, like so. For the direction,
so for the direction, roughly about 10-15 degrees medially, right? Because you don't want to hit the hypoglossal nerve in front. And then on the lateral view, use your image, use your X-ray, right, to guide, to point towards the anterior arch of the atlas.
Here, 10 degrees. Here and then up.
Yeah, go. Okay, great fun, isn't it? Yeah.
It's fun.
All right, good.
Yes, good morning.
Chào tập tí thôi.
Là có một việc gì là có một việc là có một việc.
Mũ che.
There's now like this. There's over here is easy to pointer like this. Here teaching 9 now. 1, 4.
Yes.
Water.
Medium.
One.
Where's the marker pen? You have a marker pen?